Welcome and good evening. We're so glad that you're here to discuss cases from the community. We're going to be talking about research guiding the care of patients with colorectal cancer tonight. I'm Kristen Ciombor from the Vanderbilt Ingram Cancer Center in Nashville, Tennessee, and I'm joined tonight by some amazing colleagues who I'll introduce in just a minute. Here are our faculty tonight. We have, to my left, Dr. Scott Kopetz from the MD Anderson Cancer Center. We have Dr. Tony Bekaii-Saab from Mayo, Arizona. We have Professor Eric van Cutsem from University Hospitals in Leuven, Belgium. And we have Dr. John Strickler from Duke University. So I'm really looking forward to tonight and hearing different perspectives and how we treat patients with colorectal cancer and really talking about some of the challenges that go on, that happens with that. We do have some disclosures that are here on the slides that you can review. And this activity is supported by educational grants from Bayer, Exelixis, Lilly, Natera, and Seagen. So thank you to those companies. So that brings us tonight. We're talking about colorectal cancer, mostly metastatic colorectal cancer, but we will be talking about localized disease as well. So, and we have a really great agenda, I think, to talk about. So these are the modules that we'll be covering. There are 5 modules. We'll be talking about BRAF and HER2 in metastatic colorectal cancer. We'll be talking about immune checkpoint inhibitors in metastatic disease. We'll be talking about the evidence basis for selection and sequencing of therapies for patients. We'll talk about new agents and strategies, and then the changing management paradigm for localized colorectal cancer. So we have a lot to cover today. In addition to the faculty here joining me on stage, we do have several community physicians who are joining us and actually provide all of the cases that we'll be discussing tonight. So really challenging and interesting cases that I think we'll all learn a lot from. Okay, so why don't we get started? We're going to start with Module 1, which is the integration of therapies targeting BRAF and HER2 in metastatic colorectal cancer. So we're going to start actually before Dr. Strickler gets started with his lecture. We'll start with a couple of cases, and so we'll go to those in just a minute, and then we'll discuss some of the points that are brought up by the guest faculty. So we will get started. Here's the first case.
Good evening, everyone. I'm Neil Love from Research to Practice, and welcome to our real-world case library. Tonight, our panel of oncologists will present colorectal cancer cases from their practices and the questions they have about management, beginning with a patient of Dr. Victoria Giffi, a 40-year-old man who presented with MS-stable, pan-RAS wild-type rectal cancer and liver metastases.
This gentleman, also a totally healthy 40-year-old, developed hematochezia and hematuria and pelvic pressure, found a rectal mass, multiple liver metastases, a liver biopsy confirmed metastatic rectal adenocarcinoma. Technically, probably was not oligometastatic disease because he had more than 4 or 5 liver metastases. We started FOLFOXIRI because he's 40 years old and we wanted to try to give him the best chance possible. I gave him 6 cycles. He had an LAR and multiple liver wedge resections, 7 total wedge resections at our nearby academic center. So you can see in the pictures the liver metastases responded quite well, and I think these were after 6 cycles. I'm very curious where we are research-wise with patients in the 20 to 40-year-old range getting colorectal cancer, because in the community we are seeing it much more, and the American Cancer Society recommendation for having screening colonoscopies at 45 is not catching all of these patients.
Great questions and great case. So some of the questions brought up by this case we have listed here on the slides, and we'll kind of, I'll pick on some of our faculty to give their input in terms of what we think is going on here. So maybe Dr. Kopetz, we can start with you. I think we're all noticing the disturbing trend of younger colorectal cancer and colorectal cancer in younger patients. And while the screening colonoscopy guideline changes to 40, starting at 45 is a welcome change, I think it doesn't go far enough, right? So give us some thoughts about what is leading to these younger and younger cases, and what can we do?
That's a great question, and a really one of the medical mysteries, I'd say, in colorectal cancer. What we can say is that these tumors look very much like the tumors that we see in older patients when we look at the mutation profile and a lot of other first-level characteristics. And the etiology of this change really is unclear. It's estimated that especially for rectal cancers, which appear to be an area where we're seeing a greatest increase in young patients, we're anticipating more than a doubling of the incidence by 2030. And so if these trends really continue, we are going to see a change in this. They still are uncommon, and the questions of how do we utilize screening and improve screening, I think, still remains to be seen. I think a great progress to going down to 45, but we're not there fully yet.
Yeah, I agree. So getting back to the case, how do we think about patients who have potentially oligometastatic disease in the liver, who may be candidates for resection in the future? Dr. Saab, can you comment on how do you usually approach these patients? Is it different if they're potentially resectable or not? And then, of course, I'm very interested to hear whether you use post-operative sort of pseudoadjuvant treatment in those patients if they do go to resection.
Yeah, no, thank you. This group of patients is not an uncommon, at least in academic centers like ours, is not an uncommon group of patients to see. The question is more than just resectability. There's operability, there's also biology, there's also timing, synchronous versus metachronous, early and late metachronous. So there's a lot of factors that go into the equation. But without going through these excruciating details and taking a lot of things in account, for those that are clearly resectable with good biology, I think the data, at least the survival data, favors resection, and there's really a questionable role, although again somewhat controversial. There's a questionable role for systemic therapy perioperatively in that group of patients. The role of biologics is also questionable, specifically EGFR inhibitors in those specific patients where the data looked somewhat unfavorable. Now, for this particular patient, or patients that we call borderline resectable or potentially resectable, again with agents, with triplets, or for those patients, left side have all the good features where EGFR inhibitors may be used. We're seeing a lot of these patients perhaps getting to the point where they get downstaged and then potentially becoming resectable. So the question becomes for all these patients, is there a role for adjuvant therapy? And the data is all over the place. There was a prior study from EORTC that suggested some benefit with disease-free survival, no survival benefit. A couple of other studies in between, and then there's a Japanese study that actually showed a potential survival detriment. We actually looked at and recently published a network meta-analysis looking at all these studies. And what that study confirmed is exactly what we've seen, the trends across all these studies, is that patients who may end up with resection are unlikely from the survival standpoint to benefit from further therapy. Perhaps some benefit with disease-free survival. So I think the most important element here is sitting with the patient and discussing goals. I tend to essentially think that it's probably less likely that those patients are going to benefit from any further therapy, and close observation would make the most sense, but that goes alongside with a extended discussion with the patient.
Great thoughts. Thanks, Tony. Yeah, and I think your point that biology is the master is really the key point, and that can be really hard to tell up front when we're making plans for patients of potential surgery, but something certainly to keep in mind. So we're actually going to skip that third question because I think Professor Van Cutsem is going to cover that in his lecture. So let's move on to the next two cases actually. We can go ahead with the video.
Our next two cases are patients with HER2-amplified colon cancer. A 79-year-old man with extensive liver metastases managed by Dr. Ranju Gupta, and a patient of Dr. Shaachi Gupta, a 57-year-old man with metastatic colon cancer whose tumor, in addition, had a KRAS G12S somatic mutation.
We had the TAPER trial from ASCO at our institute, so I gave him the trastuzumab and pertuzumab as part of the trial. He did extremely well and then had progression of disease. I put him on regorafenib, and we started at a dose of 120 milligrams. He did very well. I think this is my patient who had the longest response to regorafenib. And tolerability-wise also, 120 milligrams, no issues at all. Then had progression of disease after another year, and I started him on irinotecan and panitumumab, not a very good response, and had very poor tolerability because of the rash. And then we had the presentation of the trastuzumab deruxtecan that was in HER2-positive colon cancer. So based on that, I was able to get approval for this medication for my patient as a single agent. So I started that in July. He has had stable disease so far. Any other anti-HER2 treatments that I can use? I know tucatinib was in trials in colon cancer.
My question is, would this be the patient who would benefit from HER2-directed therapy if and when he progresses? For example, trastuzumab, pertuzumab, or famtrastuzumab deruxtecan, would that be applicable? Would that work in the setting of KRAS mutation?
The question is really interesting about TDXD. How many times have you used it and what have you seen?
I've used it 3 times in breast, and it works in most patients. So 2 out of 3 times it has worked, and I haven't had any issues with pulmonary toxicity. And patients do lose hair. It is nausea-provoking. It's like chemotherapy, but it works.
Great questions. So I want to kind of address what the oncologists were mentioning. So, and we'll cover some of these questions actually in the lecture, so we won't do all of them right now. But Professor Van Cutsem, I want your opinion or perspective, especially from the European side of things. How do we use anti-HER2 therapy effectively? What are some things that you think about? What's available for you in use outside of a clinical trial at the current time?
Most of the agents are not approved yet in Europe, but we can use some of the combinations within trials or sometimes compassionate use and expanded access. And I think there are a couple of combinations for which we have all phase 2 data, and most of these data are in RAS wild-type patients, HER2 positive, with the classic criteria of HER2 positivity, and that's either trastuzumab, lapatinib, that can be trastuzumab, pertuzumab. The phase 2 data gave us responses around 30 to 35%. Or that can be the newer agents, trastuzumab deruxtecan, or tucatinib plus trastuzumab. These last 2 drugs or regimens gave response rates in phase 2 trials of around between 40 and 50%. We don't have cross-trial comparisons to see what is the best of these different combinations. But if we would have free use, let's say, without restrictions for reimbursement, then the choice could go to trastuzumab deruxtecan or trastuzumab plus tucatinib. But it's sure that we should combine trastuzumab on itself is not active, lapatinib on itself is not active in these patients.
Thank you. And Dr. Strickler, how many patients are we talking about that would qualify for these agents, and what are some of the key points in terms of eligibility when you're thinking about anti-HER2 directed therapy?
Yeah, so overall, about 3% of patients with metastatic colorectal cancer have HER2-positive disease or ERBB2-amplified disease. But what we found is that the rates of HER2 positivity are much higher in patients who have RAS wild-type and BRAF wild-type disease, all microsatellite-stable. So while it's rare, we do know where to look, and it tends to be left-sided primary as well. Certainly there are a number of factors that come into play when we're choosing the right therapy, but a highly amplified left-sided RAS wild-type HER2-positive cancer is likely to do quite well with any anti-HER2 therapy, and then I'll go into more details here in a moment on that data.
Thanks. Scott, just on a practical level, when you give trastuzumab deruxtecan, how do you screen for interstitial lung disease? It's always the feared complication, of course. How worried are you about that, and any particular things that you look for?
Yeah, I think the key is just to have it on your radar and make sure that your staff also recognize that, because sometimes the first call for cough comes into the staff and may not always trickle up to you. And really, it's not something that I'm proactively imaging, but really being reactive. But the hope is to be rapidly reactive to new pulmonary symptoms that are coming in.
Mm-hmm. And Tony, one of the oncologists mentioned that this seems, trastuzumab deruxtecan seems like real chemo. Is that your impression too? What do you think about the adverse event profile there?
Yeah, no, trastuzumab deruxtecan is a chemotherapy with essentially a targeted chemotherapy, I should say. So it has the benefits of cytotoxic therapy targeted to HER2. The way I think about trastuzumab deruxtecan, it's essentially, and that's why its utility, it's primarily following, combination or anti-HER2 therapies like trastuzumab, pertuzumab, or tucatinib, is all what it cares about, in simple terms, is the presence of the receptor. It doesn't care whether the receptor is relevant in terms of its biology or not. And that's been shown in the trials, is that it works equally well in patients who have been pre-exposed to other anti-HER2 therapies or in those that are anti-HER2 naive. So frankly, I think about it mostly, and its toxicities are very similar to what you would expect from chemotherapy toxicity, somewhat attenuated because it's more targeted.
Thank you. And with that, we're going to turn the podium over to Dr. Strickler, who's going to tell us a little bit more about therapies targeting BRAF and HER2.
Thank you so much. It's a pleasure to be here tonight. And the topics here that I'll cover are BRAF and HER2 and metastatic colorectal cancer. So I'm going to start with a confession, and that is that a few years ago I made a pie chart of the actionable targets in colorectal cancer. And I liked it because it was very simple and easy to remember. But also I'm responsible for the molecular tumor board at Duke and know that this is probably not an accurate way to portray our actionable targets, which really look much more like this. And this is a messier picture, but this is the real world setting. And really what this figure shows is that many of these actionable targets are overlapping. So looking specifically at BRAF V600, about 30% overlap with MSI high. And then with HER2 amplification, which I'll also discuss, about 25% overlap with a KRAS mutation. So when you actually get into the actionable alterations, life is far more complicated. And so as I mentioned, about 3% of patients with metastatic colorectal cancer have HER2 amplification, and that tends to be enriched in this RAS and BRAF wild-type population. It's around 5 to 10% in both single institution studies and then out of the Heracles trial. So we can thank the Italians for making HER2 an actionable target in metastatic colorectal cancer. This is long-term data from Heracles A from Italy, where they found a 28% response rate in long-term follow-up of 32 evaluable patients, progression-free survival of 4.7 months. And based on this was the first anti-HER2 regimen that landed in the NCCN guidelines and also in Europe. So we also have trastuzumab, pertuzumab. There have been multiple studies looking at this combination in HER2-positive metastatic colorectal cancer. We see response rates in the 25 to 35% range, PFS right around 4 months. And that has been followed by Destiny CRC01, which looks at the antibody-drug conjugate trastuzumab deruxtecan in HER2-positive metastatic colorectal cancer. Here they showed an impressive 45% confirmed objective response rate, median duration of response 7 months, PFS 6.9 months. So this also entered into our NCCN guidelines. I will point out this is a higher dose, 6.4 mg per kg, than the FDA-approved dose level for breast cancer. And it is an antibody-drug conjugate, so it does have toxicity more akin to cytotoxic chemotherapy. So we see nausea, appetite loss, and cytopenias. And then I'll cover the interstitial lung disease or pneumonitis here in a moment. DESTINY-CRC01 also did some interesting work looking at which patients respond to this therapy. And interestingly, most of the responses occurred in patients with IHC3+ disease with a response rate of 58%. There were a few responders among the IHC2+, but really minimal response in the HER2-negative group. So that hasn't had as much follow-up. Interestingly, response rate was nearly identical between those who had never received an anti-HER2 treatment before and those who had. So it didn't appear to matter. It suggested that a patient could progress on a trastuzumab-based combination and then go on to get trastuzumab deruxtecan and do just as well. So as I mentioned, DESTINY-CRC01 did see some additional toxicity. 8 patients total had interstitial lung disease or pneumonitis. Median time to onset was about 2 months. And 3 of these events, or a little over 3% of patients, died from interstitial lung disease or pneumonitis. So this is something to be aware of. And it raised questions for me about whether that 6.4 mg per kg dose was the appropriate one here. And then I'll follow up here with Mountaineer, which several of us here have been involved in. This was a global open-label phase 2 trial looking at the combination of tucatinib and trastuzumab in patients with HER2-positive metastatic colorectal cancer. What's unique about this is we wrote the trial to be as inclusive as possible, so it allowed patients to enter the study regardless of how that HER2 positivity was discovered. The primary endpoint was confirmed objective response rate, and here the response rate was 38%. Median duration of response was impressive, over 12 months. And about 2/3 of patients had some degree of tumor reduction. Also, PFS impressive at 8.2 months with a survival exceeding 2 years, which is impressive in this chemotherapy refractory setting. Also, tucatinib and trastuzumab does have characteristic treatment-emergent adverse events, the most common one being diarrhea, but that's generally manageable, typically grade 1 or grade 2. Occasionally, we will see AST and ALT elevations in the 2 to 3% range. So my final thoughts, when I have a patient with HER2-positive disease in the clinic, I'm obviously excited for that patient because it means that I can give them targeted therapies. We have this new regimen entering the clinic, tucatinib and trastuzumab, which is a chemotherapy-free regimen. Also, trastuzumab deruxtecan is clearly active and retains that activity even after a patient progresses on a prior anti-HER2 regimen. So I'm going to move on now to BRAF, which BRAF V600E specifically, which is seen in about 7% of patients with metastatic colorectal cancer. It's typically right-sided and associated with very poor prognosis. And it has taken us a long time to figure out BRAF in metastatic colorectal cancer. Make a long story short, it appears that we need to inhibit not just BRAF, but also upstream with EGFR. And then also the triplet had some activity as well. The Beacon CRC phase 3 study is shown here. This study compared standard of care versus encorafenib Cetux or the triplet of encorafenib Cetux binimetinib in patients with refractory metastatic colorectal cancer with a BRAF mutation. Primary endpoint was survival. And here, both the triplet and the doublet showed a statistically significant improvement in survival, but you'll notice that the median survival was identical for the triplet and the doublet, 9.3 months. Additionally, response rate similar between the doublet and the triplet, maybe a hair better for the triplet, but just numerically, I think the safety and tolerability was best for the doublet of encorafenib and cetuximab. And based on this, the FDA-approved standard now is encorafenib and cetuximab in this second-line setting and later. Following up on that, certainly there was a question about whether there could be a role for an anti-BRAF regimen in the frontline setting. This is the Anchor CRC trial, which I believe you presented a couple of years ago at ESMO World GI. This showed an impressive response rate for the triplet of encorafenib, binimetinib, and cetuximab, 48%, with a PFS of 5.8 months and median OS of 17 months. Certainly suggested there could be a role for an anti-BRAF strategy in the front line, which led to the Breakwater study, and I'm just going to wrap up with a summary of this. This is a study that is designed to compare standard of care versus encorafenib and cetuximab versus encorafenib, cetuximab, and chemotherapy. The safety lead-in was presented this past fall at ESMO. And key points here is that safety for the FOLFOX and the FOLFIRI backbone with encorafenib and cetuximab was well tolerated for both backbones, and similar toxicity profile for both. I will point out that the response rate was outstanding for both encorafenib cetux FOLFOX and encorafenib cetux FOLFIRI. And PFS also impressive for all of the backbones. Now, the conclusion was that FOLFOX would be the preferred backbone, but certainly many of us in the audience were wondering why, because FOLFIRI also looked like a great backbone with encorafenib and cetux as well. So, to summarize, when a patient with BRAF V600E-mutated colon cancer comes to my clinic, first line, I'm currently doing chemotherapy and anti-VEGF, with second line encorafenib and an anti-EGFR, and I look forward to seeing the results of these promising first-line trials, which should be reporting out in the future. Thank you.
Thank you, John. It's a great discussion and two very interesting topics that have really revolutionized our treatment for these subsets of patients. So we'll move on now to the next module. So next we'll be talking about optimizing the use of immune checkpoint inhibitors in the management of metastatic colorectal cancer. So we'll start again with a couple of cases.
The next case is a patient of Dr. Amber Xu, a 54-year-old man with BRAF V600E-mutant metastatic colon cancer.
I decided to start him with FOLFOXIRI, and later I added bevacizumab after he healed completely from the surgery. It was about a year later when his CT scan showed progressive disease, and I started him on the second-line treatment with cetuximab and encorafenib. He actually had some skin rash, but cancer was under control for about 6 months. So my question is that, we know BRAF mutation is usually associated with poor prognosis. How do the expert panel kind of decide on these first-line options? And what factors will influence their decision-making? And when this patient progresses on the target therapy, is there any utility of combining target therapy with addition of chemotherapy? We should completely switch over. How do the expert panel decide between the options such as regorafenib versus TAS-102? And I would also love to hear how they use regorafenib, how they dose it.
Have you ever used TAS-102 and bevacizumab?
Occasionally, yes. Like a couple cases, we've tried that.
All right, great. So I told you we're moving on to immune checkpoint inhibitors, but not yet. We're still talking about BRAF. So Eric, why don't you take this question in terms of give us your thoughts about whether bevacizumab should be added to TAS-102. What are the data, and maybe even data we'll be seeing this week. But what is your current practice?
Well, this is changing current practice. We will see on Saturday a presentation of the randomized phase 3 study TAS plus or minus bevacizumab. The results are not yet available, but the abstract is publicly available since today, and it shows that the addition of bevacizumab to TAS in a phase 3 trial improves the survival, and quite important improvement with more than 3 months. But that's the only information that we can see online right now. The rest will be presented in the main session on Saturday here. But having said that, we had already some phase 2 data also from Denmark and from Japan, and Denmark even randomized phase 2 data saying that TAS plus Bev was better than TAS. So we have moved implementing that, and I guess this data that Dr. Tabanero will present on Saturday will be practice changing. Mm-hmm.
Great. Yeah, we're very much looking forward to seeing that presentation. Scott, kind of moving back a little bit, in the BRAF setting specifically, outside of a clinical trial, what are you doing first line? Are you doing triplet? Are you doing doublet with Bev? What are kind of your thoughts there?
Yeah, this is an area that I think several years ago there was a small series that suggested that perhaps a triplet, cytotoxic triplet, could be more active in BRAF setting. I think now we've learned that this isn't really predicting for more activity of the triplet than, say, a doublet, but that the same principles I use and apply. That who do I use a triplet cytotoxic therapy on? It's a patient that has aggressive disease, bad biology, bulky disease, where we really are trying to maximize response. And that does include a lot of BRAFs, but not all of them. And so I would say it'd certainly be an option that I would consider, a FOLFOXIRI Bev combination for these patients, but we shouldn't feel that we have to utilize that for all patients.
Great, thank you. And Tony, the community oncologist wanted to know, how do you dose regorafenib? I know you have some thoughts about that.
Is that a trick question?
It's an easy one.
And you were part of that study as well. But, so dosing regorafenib is, the initial approved dose was 160 milligram daily, 3 weeks on, 1 week off, which was pretty brutal and tough, quite tough on patients. And there was a lot of maneuvering around that dose without data, and we ran a study called REDOS, essentially looking at a dose escalation strategy. So starting with 80 week 1, then 120, then 160 as tolerated, and then a week off. And this actually turns out to be a superior strategy versus regorafenib, 160 milligram. So the standard dose did improve actually the likelihood of patient getting to cycle 3 and going beyond. Did improve survival, although it was secondary endpoint, and ended up improving quality of life and toxicity. And so I would say, in my viewpoint, the right dose with a bias is the 80, 120, 160. So the REDOS strategy, so the dose optimized strategy.
That's great, thank you. Okay, we'll go on to the next case, which is MSI high, and here we go.
The next case is presented by Dr. Farshid Dayyani, a 67-year-old man with locally unresectable MSI-high carcinoma of the cecum.
Clinically, it was a T4B-N1, no distant metastases. So upfront, likely unresectable, deficient MMR, right-sided, colon cancer. The question is, how do you treat that? Do you give upfront FOLFOX, old school? Or do you try to take into account that the patient is MMR deficient? Do you include a checkpoint inhibitor? Would you combine it with FOLFOX at least for 2 to 3 months to further shrink the tumor prior to possible resection? I started him actually on FOLFOX because the IHC wasn't there yet. But between cycle 1 and 2, the IHC came back with the MSI high status. And at that time, I decided to add pembrolizumab to his regimen, and you can see he had a very nice CA decrease. His CA was never very high. I sent his MRD assay as well at baseline, and as you can see, he normalized the MRD assay, or almost normalized it after 3 months of treatment. So now the question is, when would you proceed with resection, if at all, and how long will you give the pembro?
Great question. This is all becoming a controversial area a little bit. At least, it's good to have more options, but can sometimes be tough to know what to do. So let's start with you, John. Locally advanced, unresectable MSI-high colon cancer. Do you do FOLFOX, or do you start with pembro or nivo or something else?
Well, colorectal cancer that's unresectable is, by traditional definition, being treated with palliative intent. And so for me, that would follow a palliative regimen. Keynote 177 showed the superiority of pembrolizumab over FOLFOX. And for me, that would be the preferred choice in this case. It also generates fairly high response rates as well. And it's, for me, the only open question is whether we're thinking about pembrolizumab or something even with higher response rates, like ipi-nivo, and I think that's very debatable whether you would bring in the combination. But I think most likely I would just go straight to pembrolizumab.
Great. Scott, do you ever give chemo plus checkpoint inhibition? Have there been any instances in which you've thought about that?
Yeah, I mean, it's a good question. I think we have safety data that it can be done. There are certainly questions about whether it's superior. There's a lot of talk about some of the early progressions, and maybe can you mitigate some of those early progressions on the PD-1 inhibitors. There's a clinical trial looking at that now, but we just don't have data. So I think it's rare that we do that, but certainly understand in this case, initiated on FOLFOX and the impetus to continue it.
Great. And Eric, circulating tumor DNA, do you think it has a role in assessing, I mean, we saw the response. Do you think that that can help us guide whether patients are responding and be utilized in real time for treatment decisions?
Yes, it has clearly great potential in this setting because this is a patient without metastasis, evaluating the local tumor and to see whether the patient has a complete response on a CT scan or an MRI is not always so easy. So circulating DNA can for sure help in this situation. And remember that the niche study that was presented by our Dutch colleagues recently in patients with resectable colon cancer, but without metastasis also led in the majority of patients to a complete response in this setting. So it's quite often that you may see in these patients without metastasis a complete response, and circulating DNA may help really to judge whether there is still any activity.
Scott?
Yeah, I'm just going to make the point, and I completely agree with that, but also that ctDNA, the characteristics of it have very high positive predictive value for residual disease. So the question is, has this patient achieved a complete path response at this point? And should we stop or do something different? I think the answer is we can say with a fair degree of confidence that no, there's still disease there. Head in the right direction, keep going, but can you get to that, can you keep driving that? And I think really what you want to see is a complete clearance of ctDNA. Not that we know that will always be associated with complete path response, but if that's the goal, we're not there yet.
Tony, how about for the upfront resectable MSI-high colon cancer patient? Are you adopting niche 2, where you're doing upfront immunotherapy, or are you still going straight to surgery?
It depends who gets the patient first.
Yes, that's a good point.
But I think, and I actually am going to go beyond, I know this is colorectal, I'm going to go to GI overall. And MSI-high localized disease, I'm actually sitting with the patients and having the discussion about, the potential to spare some patients the need to go to surgery. Most of these diseases actually tend to be local or localized. Usually, and when they come back mostly locally. And so one could frankly think that we can potentially, we still need long-term data, but we could potentially cure those patients with IO without the need to go to surgical resection and leave surgery for salvage for a lot of these patients. I mean, again, I've done it in rectum, I've done it in pancreas, I've done it in gastric. Successfully for many patients, and I do believe that's probably the way we're going in the future.
Yeah, the question is, I agree, but the question is whether we should do that in all patients with colon cancer. Rectal cancer, for sure, I don't think there is any doubt in this situation, because surgery in rectal cancer has a lot of morbidity. Patients may have a Large syndrome afterwards and so on, or sometimes a colostomy. But in colon cancer, if you have a tumor in colon descendants in a fit patient like you, Tony, the question is whether you would not do surgery in these patients. I don't think we can make a statement today that
my statement
is standard.
No, it's not standard.
Surgery is still standard.
What's standard is a discussion with the patient. That's my point, is that I think with what we're saying, it's worth actually sitting and having a discussion with the patient. We can have our biases one way or the other, but even colon surgery can have its own morbidity. But I do agree that, for most of these patients, you're still going to end up in surgery one way or the other. And then the question that comes about, do you really then need to go a neoadjuvant strategy? I mean, most of the neoadjuvant strategy with colon cancer have not really been, too successful, mostly because those patients almost never get to us, unlike the rectum, unlike the gastric, unlike the pancreas. But I do think that, there's nothing to think about colon that wouldn't be different about the other patients with these caveats in mind.
But I think that the point you're bringing up here is that it's not typical workflow for a patient to have an informed discussion with us before they go to surgery for, say, a local colon cancer. And usually we're finding out after the surgery has already happened that they have MSI high or mismatch repair deficient disease. So it's not at least in most clinics, it's not an informed discussion, right? Because you only learned after the fact. The other part of this that I think you were alluding to is that the cure rate, the prognosis for a patient with stage 2 colon cancer that's MSI high is very favorable. And with cure rates being in excess of 90%, it makes it difficult to go away from a standard of care option when the standard of care is so effective.
Thank you, John, and everyone. Clearly an area where we need to have further discussion and think about this some more. But in the meantime, I'm going to move on to just a few slides reviewing the data of immune checkpoint inhibitors in the management of metastatic disease, so moving back to more advanced disease. Scott will actually cover a little bit more about the localized setting in a little bit. So as we know, we now have several trials looking at the efficacy of immunotherapy in MSI-high metastatic disease, which really in the last 10 years even has revolutionized this subset of patients and their treatment. So we know now that many different PD-1 and PD-L1 and CTLA-4 antibodies are really helpful in this disease. So the KEYNOTE-177 was the phase 3 that really demonstrated the superiority of upfront pembrolizumab versus investigator choice chemotherapy in patients with untreated stage 4 MSI-high disease. And here the primary endpoints were twofold, both PFS and OS, but the patients who went straight to chemotherapy did have the option to cross over at progression. So what we saw here, progression-free survival, clearly favored pembrolizumab, and you see the flattening of the curves here, which really show the duration of response, and which is really nice to see and not something that we've seen in metastatic disease much before this. Response rates were pretty robust, 45% in pembro and 33% with chemotherapy. I think it brings up the question or the comment that not everybody does respond. So it's important to not assume that this is going to be the magic bullet for every patient. And we still have more to understand in terms of why some patients are resistant to checkpoint inhibition, even in the MSI-high setting. So in terms of overall survival, this was not statistically significantly different between the arms, but that was largely because the crossover rate was so high. About 60% of patients who got upfront chemo wound up crossing over, so that impacted the survival curve. So in addition to pembrolizumab, we know that Nivo and Ipi are also very active in this disease, and MSI-high disease in particular. So the checkpoint 142 looked at different cohorts. It was a non-randomized phase 2 looking at both in the second line and then, of course, in the first line, the combination of Nivo and Ipi. Here we saw, again, very nice curves. You'll see really in the first line in particular, the line in black there, the combination of Nivo-Ipi, this is low-dose ipilimumab, which is nice to remember. The really long PFS rates, so 60-month PFS rates, really incredible. In cohort 1, 34%, 52% in cohort 2. So those were the two combination arms there. Again, not randomized data, but good to look at together. In terms of overall survival, median overall survival in cohort 1, the first line Nivo-Ipi was 44.2 months. So again, we're seeing very durable responses in many patients. So unfortunately, we don't see those types of curves in microsatellite-stable disease, and that's, I think, one of our biggest challenges right now in terms of seeing if we can get immune checkpoint inhibition to work in microsatellite-stable disease. So there are a host of reasons why this doesn't work as well. In contrast to MSI-high disease, there's a much lower tumor mutational burden and low immunogenicity for CD8 T-cell recognition. There are defects in the antigen presentation machinery. There's overexpression of immunosuppressive pathways, and then the tumor microenvironment itself is very immunosuppressive. So I've always liked, I know this figure is from a while ago now, but I always think that it's a really good one to think about. So when we think about why does immune therapy work, especially in MSI-high disease, and why doesn't it work in microsatellite-stable disease, you have to think about the underlying biology. So typically, you have constitutive oncogenic signaling, which induces the PD-L1 expression on the tumor cells. And you can also get T-cell-induced PD-L1 upregulation, so different mechanisms. In MSI-high disease, you have that strong anti-tumor immune response, that so-called hot tumor, right? And then you get PD-L1 upregulation. So then when you hit it with the checkpoint inhibition, you're going to see a response. However, in microsatellite-stable disease, you don't have that endogenous anti-tumor immune response. You don't get the PD-L1 upregulation. You have that cold tumor. And so just giving PD-1 inhibition alone is not going to work. So really what we need to figure out is, how do we induce that anti-tumor immunity? How do we increase the immune response and the PD-L1 expression so that we can get immunotherapy to work, checkpoint inhibition in particular? So there have been a host of studies that have tried different combinations with PD-1 inhibition. So of course the Rego-Nivo study, which in the phase 1 in Japan looked initially really interesting. Subsequent studies really kind of didn't show as nice of responses or outcomes for patients. But we did see that in the patients who responded here, they were primarily all the patients who did not have liver metastases. So something to keep in mind in this, but overall, a little bit disappointing. In the same vein, the Rego-Pembro study in microsatellite-stable failed to improve PFS, that combination, and no real new safety signals there. I think we're pretty good at giving Rego and Pembro, and the combination is manageable. But again, saw that signal that patients with no liver metastases and those with prior radiotherapy in some cases had a longer PFS. So moving on to pembrolizumab in the LEAP-005 study, which was really a host of different solid tumors, but pulling out the data from GI cancer specifically, saw in the middle column there on the right, the third line colorectal, about 22% response rate, disease control almost 50%. And what was interesting is that the PFS was pretty short, median overall survival 7.5 months, and the median duration of response, so those that did respond had not yet been reached. So that led to the LEAP-017 study, which we're awaiting data from. So this is, again, microsatellite-stable patients who had progressed on standard of care therapy or could not tolerate it. And the stratification factor here was liver metastases. So whether or not you had that, patients were randomized to pembrolizumab versus regorafenib or TAS-102 at standard doses. So we await that data. So and then COSMIC-21, there was just pulling out some data from cabozantinib atezolizumab, so different TKI and immunotherapy combination. One of the cohorts, the colorectal cohort, was especially interesting. And we saw that, of course, as you might expect, the AEs leading to dose reductions or dose delays actually was quite high, in my opinion. But the response rates were interesting in that the patients with wild-type RAS actually seemed to do better. So again, maybe there are subsets that could potentially benefit, but on the whole, a little bit disappointing. So then, utilizing cabozantinib plus durva, the Camilla study, again, a colorectal cohort, was looked at, and response rates were about the same, about 27%, but the disease control rate was about 86%, so higher than we've seen in some of the other combinations. And again, the RAS wild type, half of the patients who responded were RAS wild type. So cabozantinib, there's XL092. How are they different? And why are we talking about these two drugs? So they're both ATP competitive inhibitors of multiple receptor tyrosine kinases, especially VEGFR2 and MET and others. In syngeneic tumor models, at least, XL092 plus immune checkpoint inhibition actually looked to have higher efficacy. And so the main difference there is that cabo has a much longer half-life than XL092. So there are ongoing studies, especially Stellar 303, which I'll tell you about in just a second, looking at this combination. So Stellar 001, though, was the dose escalation portion in multiple solid tumors, and looking at the XL092 either as monotherapy or in combination. And this is a little hard to see, but there were a host of tumor types that were represented here, both in the top as monotherapy and then as combination with atezo. And so that led to the design of Stellar 303, which is the phase 3 of XL092 plus atezo in second line and beyond metastatic colorectal cancer. So again, microsatellite-stable. So this design is actually, the stratification factors include RAS status and liver presence of liver metastases or not. And patients are randomized to either the combination or control, which is standard dose regorafenib. So that will be interesting to see, I think. Let me see if we have any questions. Maybe we have time for just one before we move on to the next module. All right, so this is a common question. Scott, I'm going to turn this over to you. So what if, and we see this pretty often, patient has MSI-high disease and BRAF mutation, V600E. Which do you target first?
Yeah, I think just given that you can cure patients with MSI-high with immunotherapy, that really trumps the BRAF. And I think you can certainly follow that up with BRAF-targeted therapies. I will mention there's a phase 2 study looking at whether BRAF targeting and immunotherapy, a lot of good rationale why that may actually be better. So that's the CMARC study that's ongoing to explore that question.
Great, thank you. All right, let's move on to module 3. So this is where we talk about how do we select and sequence therapy for patients with metastatic colorectal cancer. And we have a case.
The next case is presented by Dr. Liudmila N Schafer, a 79-year-old man with metastatic rectal cancer and newly diagnosed PMS2-positive Lynch syndrome.
He actually has few comorbidities, coronary artery disease and stent, and he smokes, and he is in a wheelchair. Disease started progressing very quickly. When I saw him, he was already stage 4, and he said that he agreed for any options but non-chemo. And in the current society, Neil, when we actually see the patients, now this new theme of non-chemo, very, very popular. So we started him on pembrolizumab, and he actually have been since June last year on pembrolizumab, stable disease, CEA decrease. How does the faculty approach variant of unknown significance of MMR deficient patients and confirmation with germline test, especially considering that still number of undiagnosed Lynch syndromes in the community?
So I think that's a great question, and something that we have to keep in mind that, not only does treatment, the MSI status determine treatment, but also it's really important to think about potential hereditary factors as well. So John, how about, what do you think about do you send every patient for germline testing if they're MSI high? How do you think about who you're going to test and who you might think has Lynch syndrome versus sporadic MSI high disease?
Yeah, increasingly, and I think the guidelines are catching up to this, all patients with MSI high disease, well, okay, there is a caveat. All patients who have BRAF wild type MSI high disease would receive germline testing We think of the BRAF V600E mutation together with MSI high signifies more of a sporadic type of MSI high. So that's not likely to be Lynch syndrome. So that's just a brief answer to that question.
Yeah.
There's a much longer answer that we could give the first-year fellow.
But if I may, on this, I agree that's the academic way to do it. But I think that, and we've published that data, and I think the NCCN guidelines have included this as universal germline testing. So I don't even need to think or be smart about this anymore. I just do it automatically, which I think.
And I think that's reasonable. Yeah.
And are you, just out of curiosity, in polling the group, are you sending patients to genetic counseling, or are you doing the germline testing yourself with the panels, Invitae?
Doing automatically, at least in our practice, everyone is getting germline testing, and then they get to. So the counselor, the genetic counselor, is reviewing those because as it goes. Our workflow is that as we order the test, there's an alert that goes to the genetic counselor, and so the test comes to the two of us, and I always get a note whether they need to see the patient or not based on the results of the test. So life has become easier.
That is a good workflow.
Yeah.
We all need that.
I love it. Yes, I love it.
All right. And then coming back, I think we touched on this a little bit, but first-line therapy for MSI-high colorectal cancer, hopefully I've convinced you that for the patients who are eligible for immunotherapy, we should be doing that. But what do you think about in terms of Nivo-Ipi versus Nivo versus Pembro? What are some considerations? Eric, do you ever do doublet immunotherapy? Do you do that preferentially, or do you just stick with monotherapy and see?
Well, at the moment, we still do a Pembro monotherapy as standard option. We have interesting data, as you've shown, of Nivo-Ipi. There are no randomized data yet available of the comparison of a PD antibody versus PD plus CTLA-4. That study is finishing recruitment, AWH study. So that will answer the question. But in the vast majority of the patients, the preferred treatment is, for me, Pembro monotherapy.
And Scott, one last quick question before we move on to the next case. How long do you treat? If patients are responding, do you cut it off at 2 years? Do you stop earlier? What do you do?
Yeah, we've been cutting off at least at 2 years, and sometimes for some patients earlier. We go at least 1 year, but not past 2.
Okay, great. Okay, next case. I'm going to move on.
The next case is presented by Dr. Warren Brenner, a 54-year-old man with pan-RAS wild-type metastatic rectal cancer treated with FOLFOX and cetuximab.
Previously healthy, presented with a rectal cancer, extensive pelvic lymphadenopathy, as well as a single isolated bone lesion in the left iliac wing. Initiated therapy with FOLFOX, and once we had the genetic sequencing back, we elected to add cetuximab to his treatment, but he discontinued it after 1 dose due to a significant skin rash and refused to receive it anymore. So my question for the investigators are, what are they using in the frontline setting in patients who have left-sided disease, pan-RAS wild type? Are they using an EGFR inhibitor, or are they still using a VEGF inhibitor such as bevacizumab? Is disease in the transverse colon considered left-sided or right-sided disease? Are they using Q2 weekly cetuximab dosing, or are they still using weekly cetuximab dosing? Is EGFR inhibitor combined with FOLFOX versus FOLFIRI, and is there any role to combine it with FOLFOXIRI? Do the investigators ever use 5-FU plus an EGFR inhibitor as a maintenance strategy in patients with left-sided colorectal cancer? Do they have any pearls about the management of EGFR-related skin toxicity, and any pearls on the management of oxaliplatin-related peripheral neuropathy? Are they using preventative strategies for the skin toxicities, such as antibiotics, certain steroid creams, moisturizers, or do they wait for patients to actually develop skin toxicity?
Those are a lot of questions. So I'm going to cherry pick some of my favorites. So how about Tony? What are you doing in the first line in light of the paradigm data? Has that been practice changing for you? Were you doing that first? Were you doing that already with left-sided RAS wild type disease that's also BRAF wild type? Were you using anti-EGFR in combination with chemo, or do you still use Bev?
First of all, thank you for not asking the transverse colon question, because I don't know. But anyway, so paradigm definitely, our European colleagues would say it's not practice changing because they've already been doing this. So the short answer, and then very quick answer is going to be, if I was thinking about doublets, yes, an EGFR inhibitor would be added, and my preference, frankly, is to add it to an irinotecan-based regimen and not an oxaliplatin-based regimen. However, I've been using quite a bit of FOLFOXIRI and bevacizumab for most of my patients who are eligible. And as you know, the data was not really compared to a FOLFOXIRI, to a triplet. It was compared to a doublet. So I'm not sure, how that would fare out versus a triplet. And maybe link it very quickly to the maintenance strategy. I find it much easier to have a maintenance strategy with bevacizumab and capecitabine rather than a 5-FU and an EGFR inhibitor, which frankly makes actually FOLFOXIRI bevacizumab still an attractive option for many of my patients, although I will acknowledge that more patients have been moving to EGFR inhibitors in the first line.
Mm-hmm. So Eric, since you do this more often in the first line than we Americans do, what do you do in the maintenance setting? Do you continue the panitumumab or the cetuximab in the maintenance setting with 5-FU or something different?
It depends, of course. It's always an individual discussion with the patient and depends on the toxicity. But if patients had a clear benefit from a doublet plus an EGFR antibody and toxicity was not, let's say, cumbersome, then yes, we give maintenance with fluoropyrimidine with 5-FU plus panitumumab or cetuximab. There are now more and more data that endorse and that they've been looking at different maintenance strategies, EGFR antibody alone, 5-FU plus an EGFR antibody, and they all go in the same direction, that at least the progression-free survival is a bit longer if you continue, but it remains an individual discussion because it's not a big difference. But you have to discuss that with the patients. There are patients who are afraid to stop their treatment. But I never switch when the patient was on an EGFR antibody plus a doublet. I never switch in the maintenance setting then to fluoropyrimidine plus bevacizumab.
Okay, that makes sense. Good. And John, practical question: how do you deal with the rash?
The best way to deal with the rash is prevention, right? To prevent it from happening in the first place. So a few things that we do. First, we, as part of our standard order set, we'll start either doxycycline or minocycline. We will give a prescription for topical steroids, metronidazole gel. We do extensive counseling in the clinic about how to manage that rash. I am also of the mind to be preemptive in my dose reductions of anti-EGFR therapies because it can be quite severe and quite damaging to the patient when it is bad. And so I think if you are judicious with those dose reductions and use those preventive medicines, then you can start to think about incorporating it into maintenance therapies and make it tolerable to that patient. But there are also some patients where that rash is unacceptable toxicity for various reasons. And in those patients, I'm inclined to go more towards bevacizumab. And so it is a very individualized decision.
Yeah, those are great practical points. One pearl I've learned from my dermatology colleagues too, in addition to we do the same things, but they've taught me to actually culture. If the patient actually has pustules from the skin toxicity, from the rash, you can actually culture it to see if they're often minocycline or doxy resistant, and you can switch to Bactrim or something, and that can help with the rash too. So, all right, moving on. So, Professor Van Cutsem, it's your turn.
Thank you. Just to highlight some of the questions in the strategy and that may lead us to our decisions. question on left-sided versus right-sided, and the question was raised, the separation is at the splenic flexure, so the colon transversum is part of the right colon. Embryologically, it was also like that, and in the different studies, it was like that. We have seen different publications in this setting. Left-sided tumors have a better prognosis compared to right-sided tumors. And on top of that, sidedness is predictive in RAS wild-type tumors, at least in the first line. In that sense that left-sided tumors benefit more from anti-EGFR antibodies. Right-sided tumors benefit slightly more from bevacizumab, at least if we look at the endpoints of survival and progression-free survival. And that's one of the different combined analysis and meta-analysis that endorses the previous statements that we did in this ESMO analysis. So left-sided, more benefit from anti-EGFR antibodies, right-sided trend for bevacizumab benefit. If you look back to the different studies, and Paradigm was discussed already, Paradigm was a comparison anti-EGFR with bevacizumab. Initially, before the Paradigm was done, there were different studies with chemo, either FOLFOX or FOLFIRI, plus or minus an anti-EGFR antibody, and they all show similar data, a benefit in left-sided RAS wild-type tumors for the chemo plus the EGFR antibody. Whether that's with FOLFOX or with FOLFIRI, the amount of benefit is probably very similar if you look at the data. And then later on, we saw the different data with bevacizumab compared to an anti-EGFR antibody, always a chemo doublet. And the last data that were published or presented were at ASCO last year, the Paradigm, which was FOLFOX, bevacizumab versus FOLFOX, panitumab in the first line, RAS wild-type. Left-sided tumors, you can see that there was a survival benefit for the anti-EGFR antibody panitumab over bevacizumab. There was no difference in progression-free survival in the left-sided tumors, and that's consistent with the previous studies that we saw already before that. We saw also that there was, or the Japanese colleagues at least, saw that there was a benefit in response rate in the left-sided for the anti-EGFR antibody versus bevacizumab. Response rate went up from 68 to 80% in this situation. And if you look also in the right-sided tumors there, and that goes back to also what I've shown already for the analysis of left-sidedness. In the right-sided tumors, there was no clear benefit for the EGFR antibody. You can see that the survival curves here are quite similar in this setting. And as Tony already said, the Paradigm study may be practice changing. It's in fact not the first study in this setting. There are 5 studies in this setting. 3 were published before CLGB, PEAK, FIRE3, Paradigm, and Strategic, with some differences in the design, but all with the question in left-sided RAS wild-type of bevacizumab versus anti-EGFR antibody. And if you look at the hazard ratio for overall survival, there was in several studies, there was a significant benefit. In some studies, there was a clear trend. Sample size sometimes didn't make this difference, not statistically significant. But you see always hazard ratios between 0.7 and 0.82 in this situation in favor of the anti-EGFR antibody compared to bevacizumab, if you look at that, and especially also very long survival. So what is striking also is that the median survival is shifting around 40 months, so more than 3 years today in this patient population. The question that was addressed also is a doublet or a triplet in combination with an anti-EGFR antibody. I never use a triplet in combination with an anti-EGFR antibody. We didn't do that before these data were presented neither. The Italians have done a randomized study, FOLFOX-panitumab versus FOLFOXIRI-panitumab. There was no benefit of the triplet. So if you want to use an EGFR antibody, the message is doublet is good enough. Triplet doesn't give any advantages. And these different knowledges are integrated in different guidelines. In Europe, we are probably more pushing towards left-sided RAS wild type. And I would add, and that's also in the guidelines, BRAF wild type tumors, chemo doublet plus an anti-EGFR antibody is for us standard of care if there are no contraindications in this setting. Question also that I was asked to answer is, what about reintroduction of an anti-EGFR antibody? You know that in some patients we treat them, we see a benefit, we stop for one or another reason, or patients may become a bit progressive, we stop, and then we give another treatment, and the question is, can we reintroduce? We saw some initial data that this may be possible. We've seen now some data from at least 3 different studies, small studies, phase 2 studies, but using also liquid biopsies and looking at circulating DNA, and with the use of circulating DNA, liquid biopsies, and then looking whether the tumor is still RAS and BRAF wild type, whether there are no mutant clones after a certain time, that can help us to guide reintroduction. Blind reintroduction of an anti-EGFR antibody is not very efficient. That's shown in these different studies. Also in the CAVE study from Italy, it was shown that if we use in this situation, after some time, liquid biopsies, and if we are able to show that the tumor is still RAS and BRAF wild type, then reintroduction may lead into 20 to 30% of the patients again to a tumor response in this setting. What about later lines in this setting that were the new, but maybe after Saturday a little bit, for some aspects at least, some outdated guidelines already. But in this setting, in patients in third line after failing EGFR antibodies, bevacizumab plus chemo, the different chemo agents, we have regorafenib, we have TAS-102, in Europe we call that trifluridine tipiracil, and then for the molecular subgroups HER2, BRAF, if not yet exposed to that, we have or NTRK fusions, we may have these different targeted agents in this setting. The question is, what about regorafenib and TAS-102? We have different studies, the CORRECT, the RECORE study, which were quite similar in design, best supportive care versus regorafenib or versus TAS-102. You know these studies, a benefit for the different agents, similar amount of benefit in this setting. Tony commented already on the study that he led, the REDOSE study, which recommends now that regorafenib, at least starting dose in 80 milligrams, and then going up, if there is no toxicity, to under 20 and under 60 eventually. In Europe, Guillermo Gilles did a rearranged study with similar design, but also with a similar concept, but there the starting dose was a bit lower in this setting. For me, in my practice, in fit patients, I would start under 20 and then go up. In less fit patients, I would start 80 milligrams. So with these 3 dose and rearrange strategies. The question that we alluded already was this TAS-102 plus or minus bevacizumab. The Danish study that I commented already was a phase 2 study, which led to a clear benefit for combination of TAS-102 plus bevacizumab. And then there was a phase 3 study, Sunlight, that will be commented and presented by Dr. Tabernero on Saturday, randomized phase 3 study. And as we commented already, that is clearly positive for the combination of TAS-102 plus bevacizumab versus TAS-102, and which will be practice changing in this situation. Thank you.
That was a tour de force. Thank you, Eric. You covered a lot of really good data there. Okay, so we're going to move on to the next module. So we're going to talk a little bit about other promising agents and some other strategies in how we treat patients with metastatic disease. So here's our first case.
The next case is presented by Dr. Jennifer Dallas, a 50-year-old woman with pan-RAS wild-type oligometastatic rectal cancer.
This woman had presented with rectal cancer with liver metastases at diagnosis. She had oligometastatic disease, so we opted to treat her neoadjuvantly, and then she underwent resection and ablation with resection of the primary as well. And then we completed the FOLFOX adjuvantly, but then she developed new liver metastases. And since that time, we've been ablating and doing SBRT. I've had her on FOLFOXIRI with panitumumab, which she's been tolerating well. So my question for this case is, in this woman with this progressive oligometastatic rectal cancer, she should be no evidence of disease after the stereotactic radiation to the lung lesions. Is there a role for ctDNA testing to help predict recurrence?
The common question, where does ctDNA fit in? Scott, what do you think? Do you use it in the resected or status post locally, local therapy treated patients?
Yeah, so in our practice, we are utilizing it, I think, but there's a caveat because the question is, well, what do you do with the result? And I think that's something you need to kind of think through and even potentially discuss with the patient before ordering. Because a positive test, if we're not going to act on it, can certainly lead to some anxiety in the patients. Perhaps the goal is more close surveillance for those patients in that setting. I would make a plug that there's a number of novel, innovative trials in this space, and I'll cover some of those a little bit in a later segment. But I think, if you have access to trials or have that conversation, then I think it's worth doing.
Mm-hmm. Great. Tony, what about the refractory patient or this patient who's progressing and say radiographically progresses? How do you decide between regorafenib, TAS-102, TAS-Bev, fruquintinib? I mean, what are you thinking there, and how do you decide? And is that going to change in the next few days?
So, excluding the EGFR challenge strategy, which is a reasonable strategy, especially in a patient like that, I think it's getting quite complicated in the more refractory setting. Regorafenib, TAS-102 plus Bev appears to be positive, at least what we've seen on the abstract looks very promising. Fruquintinib, I can't wait to see what they're going to name that drug, actually, because fruquintinib is a mouthful. But they're all reasonable agents that appear to have similar activity. I think, TAS-102 plus Bev data appears pretty solid. Again, we have to see more details, and may end up being a preferred regimen. Regorafenib with a dose optimization strategy certainly has shown solid data, and I think fruquintinib the same. So it's going to be really an individualized discussion with a patient. My hope is that ultimately all these agents, if used with regorafenib, the appropriate dose strategy, with TAS-102 plus Bev and fruquintinib, that our patients now are going to see more effective strategies in the refractory setting in the absence of biomarker-driven strategies.
Great. And then, John, so circulating tumor DNA, not for MRD, but do you ever serially test to look for emerging mutations or alterations that might be actionable, say after a patient has been through multiple lines of therapy?
Yeah, I mean, I would say that it's an intriguing application for circulating tumor DNA. Once again, this is not an MRD test. This would be in the setting of trying to identify maybe molecular drivers of resistance. Currently, outside of a trial, we don't have a standardized approach to that. But we do know that these tumors evolve under the selective pressure of therapy. So there's been extensive work showing that, particularly in patients with RAS and BRAF wild-type disease, that a substantial proportion of them will acquire BRAF mutations and KRAS mutations. And if you are somewhat undecided about EGFR rechallenge or one of these other therapies that we've just discussed, that could be a tiebreaker for that patient, but it's not standard practice and it's not part of our national guidelines at the moment.
Great. Thank you. So we'll move on to the next case.
The next case is presented by Dr. Philip Brooks, a 60-year-old woman with metastatic KRAS G12C-mutant cancer of the sigmoid colon.
This is a very difficult case. I only recently got involved in her care. She had a lot of treatment before I ever saw her, primarily through our academic center. We're trying to make decisions as to what we do at this point. The important thing is she does have a KRAS G12C mutation. We did arrange for her in advance to get sotorasib. So we were able to, even though it's not approved for colon cancer G12C, we did get it available for her, but the data, was not looking great. My question is, should I consider sotorasib? Should I wait for her to get onto a study where she could get one of these drugs, perhaps with cetuximab? Should I do an off of study with adding sotorasib if I have it available with cetuximab? Our academic center, which is Dana-Farber, which is 5 hours drive for her, where she might be able to get adagrasib and cetuximab on study, but it was not quite ready for her to go onto it.
All right. So, Tony, I'm going to throw this one to you, even though you're going to, I'm sure, elaborate more on this in a few minutes in your talk. So, should community oncologists or should any of us be using sotorasib or adagrasib monotherapy in KRAS G12C mutant patients, or do you think, what do you think about that data?
Yeah, so the best practice would be certainly to go for a clinical trial, but a single agent sotorasib or single agent adagrasib certainly underperform, and I'll talk in a little bit about why versus combining it with cetuximab, similar to the BRAF story with single agent RAF inhibitor, vemurafenib, and others, have not really panned out to have significant responses. Although, you can argue with sotorasib and adagrasib, you get a little bit more mileage. But most of the mileage is actually when you add an EGFR inhibitor for reasons that we'll be discussing.
Okay. And Scott, the biology of the combination. So are we just adding anti-EGFR to every combination, BRAF, KRAS G12C, or is there a reason behind it?
Yeah,
what is that?
It certainly seems like it, but it's the same biology,
Yeah.
right? That one of the ways and the reasons that these monotherapies are not active is that colorectal cancer is readily adaptable and has this and then develops this adaptation whereby it upregulates signaling through EGFR. So even though EGFR is not relevant in a KRAS mutated or BRAF mutated context, once you inhibit the oncogene, you then get upregulation of signaling through EGFR, and the blockade then can suppress MAP kinase signaling. So it's a common for the MAP kinase signaling inhibitors at this point.
Okay, great. Eric, do you see many of these patients, the KRAS G12C? Is it like a needle in a haystack, or is it more common?
Yeah, well, 3 to 4% of the colorectal cancers have a G12C, so it's not frequent, but we see them, we get them referred, we put them all on trials. We are not allowed in our setting to give them off-label use, so we put them on trials, adagrasib, sotorasib, or there are other KRAS 12G inhibitors also in combination then with different drugs, because it's clear that we have to block the pathway at different levels. EGFR is probably important, but it may well be that also other additions may lead to further activity in this setting. So and that's one of the questions and one of the trials we're doing also together with Scott and with some others.
Mm-hmm. Great. All right, Tony, I'm going to turn it over to you to talk more about KRAS G12C and others.
All right. Excellent. Thank you, Kristen. All right, so we're gonna just go straight to it. I mean, this was a dream, is to target KRAS, and a lot of us would remember that as we were thinking over the last 3 to 4 decades, and continued until actually the mid-2010s, that KRAS is not going to be a druggable target. And most of it had because of the lack of accessible binding pockets, which makes it very difficult to actually target with these small molecules. And so there were a number of strategies to target KRAS, that have been used in on clinical trials for 2 to 3 decades. Not very efficient and highly toxic for the most. And then the first signs of the dawn actually appeared on the horizon for KRAS G12C. So unlike G12D, which is the more common mutation in colorectal cancer, pancreas cancer, and others, G12V is also more common. G12C can maintain an alternative interactions with its downstream effectors through an active cycle between GDP and GTP. We'll talk about this very briefly, which made it more druggable. So, as was mentioned, these G12C mutations are present in about 3 to 4% of patients with colorectal cancer, and we know RAS mutations are negative predictors of EGFR efficacy, whether it's cetuximab or panitumumab. When you think about KRAS, protein cycles between GDP, which is the on, and then GDP, which is the off state. So what these agents, adagrasib and sotorasib, do is they essentially bind selectively to these G12C agents when they're inactive, and they just stick to the inactive state, which cycles around 24 hours. So the half-life matters here for these agents. They keep them inactive until they cycle out. Now, both as Scott mentioned, both G12C inhibitors or G12C inhibitors overall and BRAF inhibitors and others, so any inhibitor of that MAPK pathway appears to essentially create this feedback loop mechanism or reactivation of EGFR. And so this provides a rationale for combining these agents with EGFR inhibitors to optimize response. And so we recently published this. Rona Yeager led this study with adagrasib with or without cetuximab in patients with colorectal cancer and KRAS G12C mutations. And this was the Crystal-1 study. And there are a couple of cohorts were included here. So phase 1B had adagrasib plus cetuximab, and then the monotherapy, the monotherapy. So you can see that the response rate with adagrasib single agent was 23% in those evaluable patients. With cetuximab, it was double that, 46%, and everyone had a disease control rate. And you can see the waterfall plot here. They look pretty nice for this group of patients that was heavily pretreated. And we look at these plots, essentially the swimmers plot, you can see that these tend to be durable. So duration of response for monotherapy was 4.3 months, with the combo with adagrasib and cetuximab, 7.6 months. And you can see that this is a longer follow-up here, that many of these responses tend to be quite durable. And they go beyond a year and a half, and some patients even getting close to the 2 years or surpassing the 2 years. So in the published study, we included both patients with central review and investigator response. They were pretty similar, and that's good news. We know that investigator response can include certain biases, which are not necessarily a bad thing. I mean, this is how we practice medicine. We don't just rely on just the scan. But I think, where your response rate is the primary goal, it's important to have validation centrally. And the median duration of response, we've talked about that, PFS 5.6 and 6.9 months. The toxicities, essentially, the most common toxicities were GI toxicities. Mostly in the grade 1, grade 2, very few grade 3 toxicities. And of course, with the cetuximab and adagrasib, you see cetuximab-related toxicities. Although, interestingly, similar to what we've seen with the BRAF inhibitors, is blocking that MAPK pathway essentially tends to cut down somewhat on the toxicities that you would expect from EGFR inhibitors. Now, this is ongoing Crystal 10. And so that's the next study, phase 3 randomized study that's looking at adagrasib and cetuximab versus chemotherapy, FOLFIRI, FOLFOX plus whatever biologic, plus minus a biologic VEGF inhibitor in patient in second line. So this is a second line study. The other agent, sotorasib, was also looked at with or without panitumumab in a very similar design of a study. The first that was published was sotorasib single agent in that CodeBreak 100. The response rate was about 10%, but that included all patients. And you can see the waterfall plot here. The median duration of response was about 4.2 months. And then this was presented, not published yet, so sotorasib plus panitumumab. These were centrally assessed responses, 30% for sotorasib and panitumumab with a disease control rate of 93%. You can see that the follow-up is lesser here with a median duration of response of 5.9 months and ongoing responses. The toxicities, again, very similar, what you would expect with these agents, mostly GI toxicities, and then when you add the panitumumab, you get the rash, again, at a lower rate than what you would expect for single-agent panitumumab. And now this is going into this study of 150-plus patients, randomized between 2 different doses of sotorasib plus panitumumab versus TAS-102 or regorafenib. So as I said, the more common, and by the way, there are other G12C inhibitors that are in development as well. They're not there yet, but they're showing very similar responses. So consistency is good. I mean, all these agents suggest to us that G12C is a valid pathway with very consistent responses across the agents. And then the next frontier is now this G12D. There's certainly one agent, a couple of agents that are making their way in, and this is the third going in, MRTX113, which is selective inhibitor of KRAS G12D. So this study is ongoing, finished the phase 1 and moving forward. And you can see that with at least the xenograft model, you can see some really nice responses in pancreatic cancer. It wouldn't be amazing. That's about 40% of patients with pancreas cancer, if we see any of that actually in the clinic. And there are other targeted agents being developed in colorectal cancer. One that I want to touch upon very quickly is fruquintinib, which is primarily a VEGF receptor inhibitor, but also, like all these tyrosine kinase inhibitors, hits other targets, so it's not very clean in that sense, but seems to be potent, a VEGF receptor inhibitor, and it did seem to improve outcome versus placebo, both with PFS and OS. Again, not much of a response rate. And when you look at the prior TAS-102 and or regorafenib, patients, these were essentially, these patients did seem to do well, whether exposed to one, two, or both. So the toxicities here are primarily, again, linked to the mechanism of action, primarily hypertension and fatigue. Hand and foot syndrome is seen here at a rate of 20% for any grade, so a lower risk of hand and foot syndrome. But about 6% of the patients will have significant hand and foot syndrome reaction. And so there are a number of other targets that are being developed, but I think, we went through some of the more relevant ones. I know Scott will talk a little bit more about many of the other strategies, so thank you.
Thank you, Tony. Terrific. It's so exciting to see how things we thought were undruggable are actually being targeted now, and that's really encouraging for our patients. So before we move on to the next module, we got a couple minutes, so I have a grab bag of questions from the audience, so we'll try to touch on a few covering topics that we've talked about already. So John, you're first. What about, so going back to the HER2 question, is colon cancer like breast cancer? Can you treat the patients who are HER2 low? Will they respond to you? Or what about mutations, or is it just amplification?
So I'll start with the HER2 low part of it. The largest study to look at this question so far has come from Destiny CRC01, where they did have cohorts for IHC2+, non-amplified, and IHC1+, and they saw no responses. So unlike breast cancer, it appears that having HER2 low disease does not appear to be actionable for trastuzumab deruxtecan. And you know, I think that there will need to be some additional strategies that come to play for the HER2 low group. Additionally, the HER2 mutations, that's an interesting question. It comes up quite a bit because patients sometimes see their molecular sequencing reports and they come in with it and they say, see, I'm HER2 positive. And unfortunately, it appears that the HER2 mutations are not actionable to the same degree as HER2 amplification, in that most of the HER2 mutations that are known in metastatic colorectal don't create a HER2 pathway dependence. They act more often as passenger mutations that are not actionable. So that's the unfortunate fact, that it appears that most of the benefit for anti-HER2 therapies is in RAS wild type, highly HER2 positive, meaning IHC3+, or highly amplified left-sided primaries.
Great. It's a great takeaway point. Definitely applicable for us in the clinic. Okay, Eric, T4B, N0 patient, young patient who gets resected. Do you do adjuvant chemotherapy if they're MSI high, or do you just observe and see if they recur? It's a tough case.
T4B.
T4B N0, so a high-risk stage 2.
There was an R0 resection, so it's stage 2. We know that stage 2 MSI high tumors have a very good prognosis, and there is no clear benefit, at least from 5FU. You may argue whether a platinum will give a benefit, but usually I don't give these patients an adjuvant treatment.
Okay. Yeah, and I think given that we do have immunotherapy, if they do recur, you know, it gives us a little bit of reassurance at least. And finally, Tony, BRCA mutations. We didn't have time to cover that yet, but do you treat BRCA mutation metastatic colorectal cancer differently? Does that impact how you choose your chemotherapy?
Those patients, again, likely benefit from a platinum. There's a role for topoisomerase inhibitors. The good news is that a lot of my patients go on FOLFOXIRI, so they're pretty well covered across the board. The question, of course, is, do we integrate PARP inhibitors? The answer is we don't have that data at this point of time. And this is, a rare genetic alteration in this disease.
Great.
So not really much differently.
Good. Thank you. Okay, we're going to move on to Module 5. So now we're moving from the metastatic space. We've touched a little bit on localized colorectal cancer, kind of scattered throughout, but now we're going to focus on it. And we have our first case.
The next case is presented by Dr. Brenner, a 72-year-old man who has status post-resection of 2 synchronous primary T3N0 cancers of the splenic flexure and cecum.
I told him we were going to make a management decision based on molecular testing. I said, if your MRD molecular test is negative, the recommendation is going to be no chemotherapy. And then his Signatera ended up being positive with no metastatic disease on imaging. We decided to move forward and treat him with FOLFOX, given his positive Signatera.
So what are the questions we have about him?
So the number one question is, should molecular MRD testing be standard in early stage disease in order to inform management decisions? I think most people recognize, since the New England Journal article, that it's probably standard for stage 2 disease. And my question would be if any of the investigators are using molecular testing to potentially avoid chemotherapy in patients who potentially have standard risk stage 3 disease, may have 1 or 2 positive lymph nodes, especially maybe older patients. Would they omit chemotherapy if someone was MRD negative? And then, is there a role to follow MRD results in patients receiving adjuvant chemotherapy to determine length of treatment and possibly escalation or de-escalation of therapy? The other circumstance where I'm using it is in patients who have had stage 4 colon cancer potentially resected to NED, and then using molecular monitoring for prognostic purposes, as well as potentially monitoring and management decisions. Are they using it in that situation?
Great questions. Okay. So Scott, you're going to talk, I know, a lot about ctDNA and the ongoing clinical trials, but practically speaking, say you have a stage 2 patient, say an average risk stage 2 resected patient. Do you use ctDNA testing outside of a clinical trial? And you alluded to the fact that we don't always know what to do with the information. Do you think we have enough data in that setting?
I think we're accumulating the data, but not fully there yet. And so I think we in these settings are still enrolling patients onto ongoing clinical trials to understand kind of the clearance of these patients. But I think, just what Dr. Brenner, I think, nicely laid out is that conversation about what will I do with the results, right? And I just think that's such an important consideration. You can, dissect the data that we have and decide for yourself whether or not that data is enough. But I think, what we always want to do is make sure we're not just reflexively ordering something and then trying to, figure out what to do with it afterwards.
Tony, what do you think about MRD testing being longitudinal? Do you think a post-op negative ctDNA test one time negative result is good enough, or do you think you really need that serial testing?
Yeah, you do need the serial testing, certainly. I mean, it's like everything. You want to commit the patient to a test. A one-time test is really not going to be of value to them. So either you do it or you don't. And if you do it longitudinally. And I think that will provide the biggest. I mean, the challenge remains the same: is how do you use it, in helping your decision-making process, treatment decision-making process. And this case illustrates again, the thinking of a clinician who used this test essentially to make an informed decision along with a patient. It remains a challenge. I mean, we need to continue to see more data, but most of the data so far appears to be favoring a clinical utility for this test in assisting in decision-making process, whether to use adjuvant therapy or not. I mean, I think the biggest utility is going to be primarily whether we can avoid at some point, if we can show that this MRD negative disease indeed is a disease that may not require the patient to proceed with adjuvant therapy. I think that'd be the biggest win versus the other way around, the MRD positive and the initiation of chemotherapy, because that's a bigger challenge. Those patients are less likely to be cured.
Yeah. Eric, how about in your practice from the European perspective? Are you using ctDNA for MRD, or is that mostly just still an experimental?
If your question is, would you love to use it? Yes, of course.
That was the second part of my question.
The problem is that this circulating DNA testing is usually not reimbursed in Europe, and we have to stick a little bit to that a little bit. We do that a bit more than in the US in this setting. So sometimes we are faster implementing aspects, as I said earlier. Sometimes we're a bit slower. And here with this, we're a bit slower, mainly because of the fact that reimbursement authorities are a bit slower in this setting. Am I convinced? Yes, I'm convinced, and especially I completely agree with what Tony said, that this may be very helpful in avoiding chemotherapy for some patients in this setting. And then also, like the last question that is there also in the stage 4, to see whether there is really a situation of NED or whether there is still MRD, and in this situation to see in this setting whether we should eventually give or not give adjuvant chemotherapy after resection or ablation of metastases.
Mm-hmm. Great. Thank you. And John, how about you? In your clinical practice, when are you using MRD testing outside of a clinical trial? And another question is, do you think that if we do use ctDNA testing to avoid adjuvant chemotherapy, but we keep doing the longitudinal testing and the patient turns positive, but outside of the adjuvant, the standard adjuvant window, would you give chemo? I know it's very hypothetical, but just thinking through that question too.
Well, first part of your question is that, I'm a thankful that we have this available in our clinics. And I'm really using it in very different ways in different circumstances. I think that the classic application right now would be in the stage 2 setting, where frequently we're on the fence about whether to give adjuvant chemotherapy or not. The dynamic trial would suggest that we could potentially use this, and maybe we're over-treating patients in the stage 2 setting with chemotherapy. So if you're truly on the fence of whether there could be utility for adjuvant chemotherapy, it is a nice tool to help inform that discussion. But I also agree with the points made by others that you would only order that test if you knew in advance what you were going to do with the result when it comes back. So that involves a lot of counseling with the patient up front. If it's positive, we'll do this. If it's negative, we'll do that. Stage 3 is tougher because there the standard of care is to give adjuvant chemotherapy regardless of the result. So in that stage 3 setting, Scott, maybe you'll talk about this. There's an important trial ongoing in the United States, Circulate US, and that will start to answer that question of whether we can potentially withhold adjuvant chemotherapy in the stage 3 setting. In my clinic also, I really like the MRD test for patients who have chronically elevated CEAs. Even long after they've completed surgery and adjuvant chemotherapy and are deep into surveillance, that's tremendously anxiety-provoking for patients. Our national guidelines are recommending that we do PET CTs for these patients if standard CT is negative, and I think that's overscanning. So it has been quite useful to use MRD to help de-stress the situation and help to be a little bit more conservative about how we work up the elevated CEA test. Now, if it comes in positive, the data would suggest that this is a strongly prognostic test, that patient will have recurrent disease within probably 6 to 12 months. And in my experience, the MRD tests are at their best for detecting liver metastases and, to a lesser degree, lymph node metastases, not as strong at detecting early the lung metastases. But the first test I would order, because I'm so worried about the liver, would be a liver MRI. And if that's negative, I might do a PET CT to try to find it, because the first goal would be to eradicate that disease surgically. And if I can't find the disease after those tests, then I would just be on a very close surveillance plan. Now, if the patient has MSI high disease, I might be more inclined to give pembrolizumab early, but I would not give, like, let's say the person had already completed 6 months of adjuvant FOLFOX, I would not just give FOLFIRI without having measurable disease. I would want to know where that disease is. So
Great.
that would be my approach.
Thank
Long
you.
answer, sorry.
Oh, that's great. It's a complicated situation.
Yeah.
Okay, moving on to the next case.
The final case is presented by Dr. Namrata I Peswani, an 80-year-old man who presented with a stage 2 obstructing cancer of the right colon.
He's a son of an emergency room physician. He took 1 cycle of capecitabine. Unfortunately, he developed a pulmonary embolism during his first week, and he was very, very upset about this and blamed it on the chemotherapy and decided that that was not what he wanted to continue doing. So the question for him was, would the experts have offered him adjuvant therapy to begin with?
Any questions about the Signatera assay in this setting?
I definitely think it would be very helpful in trying to guide this patient about whether or not we should continue treatment. With his pulmonary embolism, he was post-op, so I'm not entirely convinced that it was chemo-related. It was just his cancer and his surgery that potentially caused it. But I think having the circulating tumor DNA test would be extremely helpful. I would love to hear how the experts decide which patient to use the assay on and how they use the results of the assay to counsel patients about their adjuvant treatment options. He always comes in with his son, who is a physician. The son's always looking for objective data to be able to guide his father. So I think having that information would really, really help.
Great. So I think in the interest of time, and I want to get to Dr. Kopetz's talk here, because I think you're actually going to cover some of this too. So we'll move on ahead, and without further ado.
Okay, thank you very much. As the last speaker wanted to talk here about the earliest disease stages. So we're going to be working backwards and talking about the role of in the changing management paradigm in localized colorectal cancer. So first, talking about ctDNA, I think this audience is familiar with this now, but just a reminder that this includes circulating DNA, but we're also seeing assays that are incorporating circulating not just DNA mutations, but also methylated DNA. But it's a very active area. We can say circulating tumor cells have not been particularly useful. We're not seeing a lot of new data in that space, but exosomes, others are an area of interest. Now, the other key point is that you have to have a right test, and there's a lot of circulating tumor DNA tests out there. What we'll be talking about is really tests designed for MRD detection, right? And this is not the Guardant 360 panel or something similar that does genotyping and profiling. But these assays really are designed and have remarkable sensitivity, right? They can detect down to 1 genome in 2 tubes of blood from patients, and that remarkable advances in technology. So you have to have the right assay for that. When I talk to patients about this, and I think it really is an amazing advance in terms of our sensitivity, and I like to point out that this is like a jump in sensitivity between a chest X-ray and a CT scan, right? That's kind of the next several log improvement in sensitivity with the caveats that we'll talk a little bit about, but really that's the potential here. These are the curves that we see, right? And these are really remarkable curves with just dramatic separations. And I want to point out a few characteristics of these assays that really help us kind of think about how do we utilize this. So first is that they have a near 100% positive predictive value, right? When they're positive, there's disease that's really there, right? And you'll see a lot of these in these curves that really come down to zero, right? It may take a year and a half, 2 years, but they come back down to zero, unfortunately. The second is that for a single test, you'll see sensitivities in that 50 to 70%, right? So these assays are single tests, and you can see, yes, there's still patients that have disease that recur that you don't see on the single test. And that's where, as Tony was mentioning, really thinking about serial monitoring is an important component to improve that sensitivity. And then the second is that there can be a lead time between the point that they're ctDNA positive and that we actually see something on CT scan. And that's kind of the gulf of opportunity, uncertainty, fill in the blank with your adjective there, but this sense of things that we're learning about. Now, just a day or two ago, we had the data that was published online from the Japanese group, the Circulate Japan Galaxy study. This was looking at almost 1,000 patients, over 1,000 patients. And this is across stages, disease-free survival by 4 weeks in a post-operative scan. So you can see we don't have the full follow-up. This is just through about a median of a year to 18 months. But amazing separation of these curves. And this is before adjuvant therapy. There are questions then about how this with adjuvant therapy, and I think what you can see here are 4 curves. What you're looking for are those patients that were converted from a positive to a negative, to those teals. And you can see that those patients who were positive, received adjuvant, became negative, actually have a fairly good outcome. But those that are either negative and positive or positive and stayed positive have worse outcomes in green and blue. The other way to look at it is how well do they clear with adjuvant therapy. And you can see there's a little bit of spontaneous clearance, but not much in this cohort, but that you can get clearance with more than 70% of patients with adjuvant therapy. Now, the dynamic study is an Australian study that asked the question. It was a kind of a randomized study looking at whether ctDNA-guided management or standard management. And this utilized a different assay. The prior was the Signatera assay. This was a separate assay now. And here, I think what I take away is the key things is that adjuvant chemotherapy was utilized less in the ctDNA-guided arm in these patients, but the oxaliplatin was more likely to be utilized in that combination, right? So less chemo, but when it was given, more intensive. And the bottom line is really recurrence-free survival was equivalent between these ctDNA guided versus standard one, and they set a non-inferiority boundary and they met the primary endpoint. So they can show not that ctDNA is superior, right, but they are non-inferior strategies, but with less utilization of chemotherapy. Now, there's efforts ongoing. COBRA study is ongoing for stage 2. This is randomizing patients that were suitable for active surveillance, so the patient physician decide no adjuvant therapy, much like some of the cases that we heard, and then patients will randomize to get the standard of care, which is observation, or have ctDNA test done and then act on that. And that one's using the Garden assay. The Circulate US effort is looking at the lower risk, stage 3. This is using the Signatera assay. When there's no ctDNA detected, as you can see on the left, patients are then randomized to that question that we all want to know. Can we use less chemotherapy? Now, importantly, it's not a one-time decision, but patients randomized, if they're negative, to continued monitoring. And then if they become positive at some later point, then go on to receive chemotherapy versus a standard. You'll see a second question on the right, which is what about if we intensify the adjuvant chemotherapy in the patients that are positive? Now, there's other efforts in this space, just highlighting a BioNTech study utilizing vaccine strategies, personalized vaccine strategies with mRNA, hence the BioNTech technology. But I think I just highlight this to say there's a lot of innovation coming into this space and really being able to select patients at higher risk of recurrence, for example. And just mention that there's a number of single-arm studies that are ongoing now in the field, looking at patients who are ctDNA positive after adjuvant therapy and surgery. You know, the question that we bring up, well, what do I do with this patient that we've tested and they want the test, and now what can we do with these results? As we said, we don't want to just start FOLFIRI in the absence of seeing any disease, but there's a number of these, and this is actually a website that was really driven by some of the patient advocates, crcmrd.org. So it's a website that has all of the available trials in this setting for patients that are MRD positive. So if you or your patients are interested in seeking out studies in these unique situations, there'll be a resource available. Now, other areas, MSI high, stage 3, we'll talk a little bit about neoadjuvant data briefly, but here's the adjuvant study ongoing, don't have results yet. This is stage 3 MSI, FOLFOX with or without PD-L1. And then just mentioning there's 2 other studies in this space, really asking the question, can we do better in the adjuvant setting with a PD-1 inhibitor? And then finally, a slide or 2 on the neoadjuvant setting. And we've talked a bit about this already, the niche study that Eric brought up. Wonderful activity in MSI high, not in MSS. And what you can see is very nice path response in the red patients there. And this was followed up on the niche 2 clinical trial where they had a complete path response rate of 67% and gave just this amazing waterfall plot. I just like to show it because it reminds me that we're making progress in the disease. So they had 67% path complete response with this area. So also let's take a look at the dostarlimab study in rectal cancer that didn't have the path data. It's kind of a clinical endpoint, but nevertheless showing similarly. And then just recently, we published the pembrolizumab data, same thing in neoadjuvant MSI high, 69% path complete response. So very consistent data in terms of the activity in this. So we are indeed curing some of these patients with localized disease. And the final point, because I can't avoid an opportunity to show at least one mouse data slide here. So, but this is the last of the evening. And this is just to say it actually makes sense to give this in a neoadjuvant setting, right? That when we administer it with a tumor intact, with draining lymph nodes, we actually can see this in mouse models as well as in patients and other tumor types. The neoadjuvant may just be the way to administer immunotherapy, and I think this is a theme that we're increasingly seeing. So I'm encouraged by the data that we see. So I'll conclude there and say, MRD, exciting, wonderful assays with positive predictive values. The applications are really guiding adjuvant therapy, doing more, doing less. But I really think the value is novel therapies in the future. We really, for all of this, have to develop the data, including how do we utilize PD-1 and MSI setting as well, and potential for organ preserving strategies. So thank you.
Thank you, Scott. Excellent. So as we wind up tonight, I just want to thank everyone for coming, both in person and virtually. I want to thank my colleagues here on the stage and those from the community who have given us great cases to discuss. I think my takeaway from tonight is just looking at all these data, how far we've come, and really what an exciting space colorectal cancer is. And we just want to cure more patients, and so we're on our way. So thank you so much for joining us. I do want to remind you that tomorrow night we'll be talking about gastroesophageal cancers, and then Friday is hepatobiliary. So please join us. Thank you.
Thank you.